Great to see some faces we haven't seen in a while.
Hello, everyone.
Hi, Kathy. How are you?
I'm well. How are you, Susan?
Doing well. Happy St. Patrick's Day. I'm assuming you might celebrate it.
Yes. Not as much as I used to, but yes.
Yeah. Yeah, none of us do that as much. Good to see you. Hmm.
Good afternoon.
Hello. Give it a couple of more moments here. Is Kate Merchant here? Just
I am.
Hi. Hi, Kate.
Hi.
I meant to get in touch with you before the meeting. I'll just turn it over to you just to introduce yourself
Sure.
at the top of the meeting. Just wanted to make
Okay.
sure you were here. Welcome.
Thank you.
Hey. I'm just looking through my list here. See, Tom is in our new offices. This is a bit of an update. We lost our offices back in 2023 in July in the first flood. Now, granted, these are our work offices. So many people lost their homes and their businesses. But we finally took over 2 years because we were dealing with FEMA and everything. Finally, are able to have a permanent home. We're on State Street at 112 State Street. So it's just really nice to have a base. So that's a bit of an update. So um, I will officially get this meeting started. So welcome everybody. Welcome to today's GMCB General Advisory Committee meeting. It is Monday, March 17th, and I want to wish everyone who celebrates a happy St. Patrick's Day. So I'll just run through the agenda and then we'll get right into it. We have a nice meeting planned for today. So we're going to give you a couple of updates and some introductions. We have a new member, a new staff member, and then Chair Foster and I are going to go over, actually, I will start and he may assist, go over the state of a few slides on the state of Vermont's healthcare. It's quite sobering, but it's important that we talk about it. And then we did send out some information on the hospital guidance that is before the board now, and we're hoping to have a conversation and input on that. So why don't I start with our updates? First, we have a new member, and her name is Kate Merchant, and she's the Director of Patient Care Services at Northwestern Medical Center. So, Abby, I think you can take the agenda down and we'll have Kate introduce herself.
Hi, everyone. Thank you for having me. I am Kate Merchant. I'm the Director of Patient Care Services at NMC. I've been here for about 9 years now in different roles. I started off as the quality specialist nurse and then have been in different director capacities here at NMC. Prior to this, I worked at UVM for 10 years on the mother baby unit, part of it as a clinical staff nurse and then as their assistant manager. I grew up and have my family here in Vermont and am very engaged in the healthcare system from a personal perspective and a professional perspective. So I'm glad to be here. Thank you for having me.
Kate, welcome. It's great to have your perspective as part of our advisory. Thank you for joining us.
Thank you.
So the other announcement, I have a couple of more, is a new staff member that I wanted to introduce to you folks. Some may know her name. Her name is Diane Lampfer, and she is the Director of Legislative Affairs for the Green Mountain Care Board. Diane, why don't you we're going to tee you up a little later in the agenda too, but why don't you just introduce yourself and share with folks a little bit about your background and how you came to be with us at the GMCB.
Well, I'm so grateful that I did. I'm Diane Lampfer. Some people who had been involved in the legislature before might remember me from that particular role. For the last 16 years, I served in the Vermont House just on a few committees, but the most recently as chair of the House Appropriations Committee. Prior to my time in service in the legislature, I actually was a state employee before and worked at the Vermont Department of Health at ADAP for many years. And I don't know if she's here, but Sandy McGuire, who is at Howard Center, not only did we know each other then, but even before that at previous other jobs. So our history goes even further back. So I'm grateful to be here and I'm sure I'll get a chance to talk more later.
Wonderful. Thanks, Diane.
Thanks.
And I do have another announcement. It's a sad announcement, but I wanted to share that Robin Lunge is wrapping up her term at the Green Mountain Care Board, and this will be her last General Advisory Committee meeting. I am so grateful for all of Robin's work that she's done for Vermonters over her many years. Sorry, Robin, but it has been many years that you have really stepped up and served Vermonters. And I want Robin offered to share what she's doing next, and I thought this committee would be interested in hearing that. So, Robin, do you want to share?
Yes. Can you hear me okay? I'm not used to wearing a headset. So, hi, everyone. I think probably everyone had heard the news by now, but my last day at the board will be April 4th, and I will be shifting over to work for Senator Welch in the Vermont office. So still in the healthcare world, just a different role. So looking forward to a new challenge, and I'm sure I'll see many of you in the future in that role, or who knows what's after that.
Wonderful. Thank you, Robin. And Robin's last day is April
4th.
But who's
Yeah.
counting? Thank you so much, Robin. And I personally am delighted that we can continue to work together, and we have our work cut out for us. So we'll be working hard together for Vermonters. Okay, great. So I am going to tee up a couple of slides. I'm here. Owen Foster is here too. I think. Yep, I see you. So these are his slides. So I'll do my best to go over them. He can add some color commentary if needed. But what I'm going to do in the next few slides is a pretty sobering view of our healthcare system in Vermont currently, and then we'll open it up to the group to discuss the information we're sharing, and ask if folks have ideas on how we go forward, because it's not an easy job that any of us have. So I'm just taking a few slides out of a presentation we did to both appropriations committees up at the State House, and these slides are publicly available if anyone wants to go through them at any time. So this is a snapshot really of the costs of insurance here in Vermont and how they compare nationally. There was a story late last year, it was a pretty long piece from KFF Health News that talked about Vermont. While we have a very healthy population and high coverage rates, our insurance itself is very expensive. And for the Affordable Care Act marketplace, you can see on the right that the Vermont average continues to be much higher than the US average. And I'm going to dig a little deeper in the next slide. So Abby, can you go to the next slide, please? So this is digging a little deeper into that information. This is the exchange plans year over year, and you can see that the affordability of these plans continues to get difficult. On the left is the annual premiums that Vermonters pay for a family of 4. And then on the right is the maximum out of pocket for a family of 4. Now, two things. Number one, you can see on the right, those premiums continue to rise and are not going in the right direction. Currently, there are federal subsidies that assist these premium payers, and they're generous and they're important, and they make it more affordable. It may not be affordable for everyone, but it definitely makes it more affordable. And this is where Robin's going to come in when she's with Senator Welch to make sure we do everything we can to sustain those subsidies, because they are slotted to sunset at the end of 2025, at the end of this year. So that is concerning, to say the least. Owen, feel free to jump in if you want to, but I'll keep going. So the next slide is, again, digging a little deeper on the insurance side. This is the risk-based capital totals and risk-based capital over time for Blue Cross Blue Shield. And I'm looking at the bottom graph. You can see the red dotted line is the low end of the range, and the risk-based capital is basically the assets to the ratio of assets to liabilities. How is the insurance company going to pay those bills that come in for all of us who are lucky enough to have insurance when we go see a provider? You can see these numbers on the bottom. The ratio over time is going in the wrong direction. Also, this is not, the other slide was going up for premiums, and this is going down for risk-based capital. So these graphs are again, all I can say is sobering. And I think it's important we're aware of this. I will say that on Friday, Blue Cross Blue Shield gave an update to the Senate Finance Committee, and I haven't had a chance to watch it yet. I will, but I know that they were giving some up-to-date financial numbers to the committee and to the public, and I don't think this is improving at the current time. So it is very, very concerning. And then the next slide, if you want to go to the next slide. On the hospital side, things are not looking much better. We are seeing the days cash on hand continue to decline in a lot of our hospitals. If folks did have a chance to look at our video and the slides we shared, We reported out the actuals for FY24, and those also, for many of the hospitals, it was not positive. So this is sobering, and this is the state of the state of Vermont's healthcare system right now, and it is something that the board and many folks in the state are very concerned about. So we wanted to put these slides out to you, tee this up, and Owen, I don't know if you want to add anything else around this, and we can tee this up and have a discussion about moving forward if you want to do that now.
Sure. I guess I'll get a quick readout on some of the things that we have been doing. I don't think they're sufficient or enough. Some are things we've been doing for a little while. Some are things that came out of recommendations from the Oliver Wyman report. And then I think there's a third bucket of other things that the state needs to be focusing on and doing. So I'll start with just sort of a couple board things, which we've been doing for the last couple years because of these problems. One is really trying to think about the system as a system and not just focusing on the entities that we regulate, but how the whole system interacts, getting better data, shining a light on different areas of the system. We've reduced hospital rate increases from where they had typically been to more around medical inflation, around 3 to 4% the last couple of years. We required Blue Cross to award rate increases or negotiate rate increases, keeping in mind the affordability, access, and quality of the providers. And that's actually had a pretty positive effect on leveling the playing field between hospital providers and non-hospital providers. We had seen pretty great disparity in prior years, and that has equalized quite a bit in the last year and a half or so. With the ACO, we really took a hard look and started questioning what the state was getting out of the ACO and whether it was working, and questioned whether or not some of the resources could be deployed elsewhere. And we directed that. We limited, I think, 3 budgets in a row and redirected some of the money to support primary care. We required OneCare to maintain its primary care funding after the Blue Cross withdrawal. And we also required them, I think this year, to support about $1.5 million more towards community providers. Looking at my notes of what else we've done more recently. The Oliver Wyman report, I think, had a lot of really, really good recommendations in it. In the legislature this year, we have voiced our support for increasing the CON thresholds pretty significantly. From around $3.5 million to 10 for the top line number. We've also supported the reference-based pricing initiatives in Senate Health and Welfare, and we've also supported the concept of having global budgets at an appropriate time, and also having a statewide plan so that we really are, as a state, having all the various pieces connect. And this is a great meeting to talk about that because we have people from all over the care spectrum. So really trying to get all of those thoughts into a statewide plan and mission, and then regulating consistent with that plan as opposed to siloed. We've also supported some legislation on taking a look at emergency authorities that may be necessary to deal with Blue Cross's solvency. It's hard to call increasing commercial rates a win, but we have supported increased commercial rates in a circumstance last year where I think there really was a risk to system-wide failure if there were solvency concerns that continued. So those are some of the things we have been doing, and I don't think they're sufficient. From my perspective, some of the federal changes coming and the just local headwinds are severe enough there may need to be more steps taken in the short run. And I think that goes to the system-wide planning and transformation. Is it a 3-year process? Is it a 5-year process? Is it a 1-year process? And do we have that much time? closures, we've seen service line changes at hospitals, and we're seeing potential insolvency at other providers. So we're sort of in this challenging space where you need to make pretty big changes pretty quickly, but you want to do them thoughtfully and planned. But at the same time, you're in a little bit of a race against unknowns and time. And some of the unknowns are broad federal, and some are just natural headwinds. So this committee, I think, is a great committee to meet with and hear other perspectives and thoughts on what we can be thinking about and doing differently, getting more boots on the ground perspective. AHS, DFR, and the Care Board have formed a group that meets at least once a week and more informally on, I don't know if we have a title or anything, but it's really emergency response. And it's trying to get an inventory of where people's finances are and where we have potential failures so that we can get ahead of them as soon as possible. And it's hard to get ahead of potential financial failures when there's no money. And that's part of the rub here is there's really not much for resources to dedicate to the problem. So we have to get pretty creative and pretty smart very, very promptly. So I'll leave it there if anyone wants to just have discussion or views or thoughts on things we should be thinking about or actions the state should be considering taking.
Thanks, Owen.
Hey, Sharon. Actually, sorry, Susan, you run this meeting, so I don't mean to
No,
call.
no,
Let's
you
have
can.
it.
I was.
No, bad
She's
habit.
like,
Go ahead.
please let somebody else run a meeting. Thank you so much, Owen. And folks, if you could, when you're commenting, just your name and where you're from. We have a couple of newer members, just so we can share that out. So, Sharon, please.
Yeah, I'm Sharon Goodwin. I own the rehab gym and representing mostly the profession of physical therapy. And I see Essex Physical Therapy is also here in the audience. I first want to mention, Owen, because you had said that payers were starting to shift more payments in equalizing. And we haven't really seen that in outpatient physical therapy. I will tell you that there's been some strong arming of the rehab gym and Blue Cross and Blue Shield. But it is my knowledge that the outpatient physical therapy industry is not seeing that improvement of reimbursements from both of the regulated insurers, MVP, Blue Cross and Blue Shield. And we have seen a significant drop, not just in Medicare, but Medicaid. And we are facing serious solvency issues across the industry. And except for like the independent PTs who don't own a lot of space, that don't have a lot of equipment, they're not in the same ballpark as like a clinic. But the ones that are in space that have a lot of equipment, and especially pools, which are very expensive, which UVM does not have, are facing some serious problems. And this year we're having to start to drop some of the insurance companies just to shift as much business into where we can start to get a footing. So maybe at another time, we can show you, because I think it's important. I think when you're hearing from maybe the payers, I think it's important to verify with the groups of people out in the community, are you seeing an increase in reimbursements? Because maybe you are hearing from the payers it's happening. And so it's important to verify just what that actually looks like. So I did testify to the Vermont Senate Health and Welfare. That was last Tuesday, and got a good response. I also emailed all of the legislators basically what I'm going to share here, and that or to dapple with trying to fix this broken system. It's off the rails and headed for a cliff. I do think that, and this isn't just me thinking, this is a national push to site neutral payments. And site neutral sounds big and scary, but it doesn't have to be if you break it into smaller steps. So instead of looking at everything like inpatient and outpatient and going site neutral, which is too much to expect, what we can do is look at outpatient primary care. And primary care is not just the doctors who measure the health, but those that are used by primary care to get a person and keep a person in good health. So it's all the therapies: physical therapy, occupational therapy, nutritional therapy, psychotherapy. All of the primary care providers, we bill with very few codes. It's not as complicated. And certainly for that which is critical, like there really isn't, if you look at the outpatient physical therapy department at Tilly Drive and you look at the rehab gym or Essex PT, you're going to see the same population and the same division of payers up till probably this year. It'll change. But in any case, it isn't like they have more critical care patients in outpatient physical therapy. But say colonoscopy, we all know that, yes, some people should really be in the hospital for a colonoscopy versus at the Green Mountain Surgical Center. But we are all in our professions trained to identify those at risk and refer them to the hospital for treatment. We don't see the hospital in reverse saying to their patients, you really should try to go to a more affordable, easy access. You can be seen sooner. In other words, the referral process shouldn't be that everybody in the community or from smaller hospitals refer into a larger hospital, but it should be the larger hospital that looks at their wait list and say to patients, you should go, one of the community providers, or you don't need to have a physical therapy visit that costs $500 when you can get it for $150. So I think it's critical, if we're serious about saving money, is we need a radical shift. And if you shift the business, we will build back what is lost. It'll take time, but we need to build up what has always been most affordable, accessible, and higher quality care. So to do the site neutral, and even just a small step, will save billions of dollars. And the effort actually from this shift of care to more accessible, affordable care will have money to put back into critical care. See, hospitals are just simply too big, too bureaucratic. It is not efficient to do community services under the umbrella of a hospital. So let's save money and then let's pay, because right now they're just cost shifting these outpatient services to pay for critical care, but we really don't, like, that's where transparency is just absent. We don't know where the money is going. We just know that it's certainly not going to cover those individuals that are coming in. And I do know that patients are bearing the brunt of it. They're going for PT visits that ends up to be thousands of dollars, where it wasn't to them. Who knows where it went to? And I'm all about cost shifting, but right now it's very much out of control. So if we save money, then we have money to reinvest within the system. We have to find out what everything costs, and then we need to deliver care where it is the best, where we can get the biggest bang for our buck, because we don't have enough bucks going around. And I'll stop there. I'll probably chime in again, but.
Please do. Thank you, Sharon. I think we don't have enough bucks going around is something I'll jot down. This is true. Rick Dooley, I see you're next.
Yes,
Go ahead.
so I thank you, Sharon, for your comments. And Sharon just beat me to the hand raising thing there, because I was actually going to say the same thing. Oh, and you mentioned the that the prices had equalized, and in primary care, we certainly have not seen that. And across the health, oh, sorry, Rick Dooley, Health First. I represent Health
Thank
First,
you,
the independent
Rick.
practices. To my knowledge, the independent practices have not seen an increase in their revenue. Now, maybe the hospital's been brought down to everyone's level, but I'm fairly certain that's not the case. And what's been the case in the past is sometimes when some services have been equalized, prices have gone up in other areas to compensate. So I'm not 100% convinced that's the case. If it is equalized, I'd love to see the data on that, because I've not seen that anywhere. So if someone could send that, that'd be great. Just a couple thoughts. What Sharon said was absolutely true. We always used to talk about the most appropriate site of care, and no one talks about that anymore. I can tell you from personal experience, the number of my patients who are sent to the ED by a UVM practice for something that doesn't need to be seen in the ED is common. And it's interesting considering, we all are talking about reducing ED utilization. I think the hospital is probably the biggest, I'm blanking on the word I'm looking for, but they're the ones who are most likely to send folks to the ED when they don't need it. Likewise, when they get to the ED, we're still in a situation where everyone who walks in the door walks away with $10,000 worth of tests. Everyone's getting a chest CT. People are getting, tests before they're seen. They're getting a $2,000 in lab tests and $2,000 in imaging, needed or not. And I'm not saying the ED's not working incredibly hard and you could not pay me enough to be in there, to be honest. However, there seems to be once you hit the ED, there's no limit on the tests that are getting ordered. Same thing for inpatient. I'm getting these discharge summaries and talking to patients after, and stuff just seems to get ordered and ordered and ordered. And after the fact, people are like, well, I guess we didn't really need those many tests. And I don't know where the scrutiny is, but if we're talking about the hospital reducing costs, I think looking at unnecessary blood work, unnecessary costs is huge. And the other thing is, I agree with Sharon, the whole not referring to an outpatient center is 100% true. The hospital does not refer to anyone. And that's where, frankly, our care in the community providers, including Vermont GI for colonoscopies and outpatient dermatology, outpatient minor surgeries, the costs are a quarter the cost of the hospital. So if the system wants to save money, the system needs to find a way to shift some of that care that doesn't need to be done in the hospital. This presumption that they need to overcharge for all these things so that they can stay in business on the high-end procedures, that system is flawed and is failing us right now. So honestly to God, I don't know how to fix the system, Owen. The system is fundamentally broken. But I think unless we make some big shifts in the way where we put patients and the care we provide for them, we're doomed to failure. I mean, we can't just keep, that chart was striking, Susan. When you look at, annual insurance premiums go from 20 grand to 50 grand a year, that's insane. So I don't know what the solution is, but I can tell you that what we're doing isn't working. And if you have the data on the equalizing of payments, I'd love to see it. Thanks.
Thanks,
So,
Rick.
on the data, the rate increases equalizing or getting closer. I'd have to check with Blue Cross on that. We've seen it. We don't go and audit and say, hey, did you pay primary care equal to hospital primary care this year? Did you pay this practice? It's much larger than that as community providers, hospital providers. That's all we get. And I think everyone here knows we're not in the business of auditing like every single particular data point that we get. But the data that we do have did show I think actually community providers may have received a slightly higher commercial rate increase than hospital providers, like by 0.1% or something like that. Very, very close. In terms of the notion of, the testing and the CT scans, all of that, that one I feel is very, very difficult for a regulator to look at because you're getting into some level of what is the practice of medicine at a particular place. And we don't have tools to do that other than a high level cap. I really like the suggestion about trying to incentivize care moving out that's appropriate to be moved out to more affordable places and incentivizing hospitals to make sure that care in the ED on weekends, there's at least an opportunity for it to go someplace that's open on a weekend, whether it be urgent care or primary care or or a mental health provider, whatever it may be. And that is something we're starting to look at, is what's going on with these ED numbers and what's being done to drive it out. And the broader notion of finding care that can be referred out, I think, is actually a really interesting question to raise. I will just take the hospital's perspective on this, is that that will change the finances, which is part of the point here, is we can't afford the way it currently is. And there has to be a appropriate way to do that. And that is what we are trying to do. We are trying to get care where it needs to be. And I think we have lost that in the last few years that I've been here. I haven't really seen a raging success on that.
And I'll say, if if you're talking about a global budget or something like that, I don't expect the Green Mountain Care Board is going to go into the ED and say, tell me who you ordered a CT on, this is appropriate, this is inappropriate. But I think if there's a cap, then the hospital then has an incentive to go in and say, well, why are we doing CTs on everyone? We don't need to do that. That's a place where we could bring our numbers down. So I think I don't think that you're going to go in and do it, but I do think that there are mechanisms to be had.
And for what it's worth, we do have a cap now.
Yeah.
Just a little high.
That's okay. Yeah, I've heard that feedback, but I've also heard it's too low. So yes, fair enough. Good point. Thank you.
Yeah, thanks, Rick. Alex, I see I'd love to hear your comment. Alex, you're not officially on the advisory, and it's fine. Maybe you should apply.
I
but
probably
I know
should.
you commented the other day. When Sharon was talking, you were talking about your pool, I think, at your PT.
Correct.
So please share your thoughts where we welcome them.
So for the record, I'm CFO of Essex PT. My main reason for joining this call today, I didn't see there was another board meeting this week, so I spent my weekend, because I'm a crazy person, looking at the CPT codes for what UVM gets reimbursed for their PT versus what we get. I wish we got equal payments from all the payers, including the public ones, but they are not as nice to negotiate with compared to Blue Cross and MVP. So hats off to them. My main concern in joining this call, and I will definitely apply if I'm allowed to after the fact, but my main concern, so the hospital gets the hospital rate fee schedule. The outpatient clinics get a separate fee schedule, which is a lot less. So I just put in our Medicare rate fee schedule. And what's concerning to me is there's two particular CPT codes, the manual therapy 97140 and therapeutic exercise 97110. Those are the top two CPT codes for the UVM billing PT department, payment wise. But on the Medicare fee schedule, out of the kind of the 5 to 7 that we use, those are the bottom two. And percentage wise, depending on what numbers you're looking at least this is my calculations, it's 358% to 427% above Medicare rates. Now, there's obviously the reduction after you bill the first unit. They don't pay that for all the other units. But I mean, I know because we have a pool, that is the #1 code billing wise for reimbursement, but that is the least amount for UVM reimbursement wise. Maybe it's because they don't own a pool, but that is slightly concerning to me. I mean, Owen asked me how many days cash on hand we had last week. Depending on the day, it's 30 to 45 days. And I think we are in a position that is way better than most companies or providers' offices. I mean, that's just my guess and my assumption, but I believe that's true. And what was really shocking last week was the revenue from commercial versus Medicare, Medicaid. So I pulled our numbers. We saw almost 17,000 visits last year, and 55% of them were Medicare or Medicaid or Medicare Advantage. So that to me, again, I know that they got to make money up for other segments in their business. PT is one of the big things that I think they should be getting a significant reduction on. Mm, I know this just because of what I do. We are very, very close in rate of pay for UVM PT, what they get paid, and what we can pay our PTs. And that's with a significant lower reimbursement rate. I know that we would be able to compete with them and offer benefits for our employees if we even got the self-pay rate that they are charging. But yeah, that's kind of my main point. And just dollars wise, I put in our units, what we billed last year to the commercial payers. I don't know what UVM's units are, but I just used their kind of fee schedule, and it is a $3 million to $3.5 million gap. And I mean, not that many people know this or probably care, but when I was at UVM undergrad, I was in a fraternity and we raised money for Hilarity for Charity for Alzheimer's and the Rallython for the UVM Kids Cancer Center. And one of the things that I did was I connected the Rallython people to a charity organization that matches money, essentially. So any money that we raised, they would match. And my up is I really think that Blue Cross and the hospital should be calling all the billionaires we have in our country and pleading for money because we are about to really kind of hit the fan. And I do not want to see our state do that. I mean, I moved back from Massachusetts to help, and it's shocking to me. But yeah, thank you. And I will apply after the fact
Thanks,
if I'm
Alex.
allowed.
Yeah, no, thank you so much for your comments. Really, really appreciate it. And I see Allison is next. And again, please tell folks where you're from.
Hi, this is Alison Ebrahimi Gold. I'm a nurse practitioner in emergency medicine, currently at NVRH.
Great.
So I have found this a very interesting discussion so far. And I do have to agree, on my side of things that we are definitely spending too much money. But I also have to raise that I think we need to probably make investments in order to save money. Because, first off, we need to get people to the right level of care. I 100% agree with that. Having more urgent cares, having perhaps even, I don't know if this would be feasible in Vermont, but the NHS has a triage line that you actually have to call before going to seek any emergency care. And I wonder if having some kind of triage line available to help direct people to their the right level of care for them. Not that you can't go to the emergency department without it, but helping to guide people because a lot of people don't understand what resources are available to them. So they'll come in, oh, my ear's been hurting for the last 2 hours. I'm like, well, it's Friday afternoon and urgent care is open. Like, why would this person come to the emergency department where they're bound to spend thousands of dollars instead of, at Express Care, it is literally walk-in primary care visit. So huge cost discrepancy in that. But the truth is, in the emergency department, when someone shows up to see me, we can't turn them away. And as much as I love the idea of doing less testing, the truth is that's a pretty hard pill to swallow when, although I carry, $6 million in liability, it's patients are very litigious. And without tort reform, knowing that somebody could come in and like argue, oh, my belly's hurting, I need to have a CAT scan. It takes an enormous amount of effort to get people to agree to not have testing done. it's probably 2/3 of my job is saying, this is why you do not need these interventions you are asking for. And people get very, very angry, threaten to sue over whatever intervention you're trying to tell them is not appropriate. Opioids, CAT scans, MRIs, whatnot. So I think that being able to help those of us in the system, the emergency department is not testing everybody for everything because we're lazy. The truth is, we don't have the information available to us from other emergency departments. So I can't even tell if someone was seen the day before at, say, Littleton Regional Hospital. I don't have access to their records during the visit unless they fax over the records in a timely manner. And we also don't have access to UVM at NVRH. So if someone's a UVM patient, I have to fly blind, which I know increases the number of tests that I have to do because I have to assume that they have everything, that they have no recent blood work or anything, because I cannot see that. So I am very curious to hear other thoughts that people have on this, but I'm glad to see us as a discussion and such open-mindedness around it.
Thanks, Allison. Thanks for your perspective, and thank you and all the providers out here for what you're doing. It's really tough work. I see Elizabeth Hunt is next.
Hi, I'm Liz Hunt. I run Green Mountain Surgery Center. And I wanted to piggyback off Allison, which something she just said, along with a couple things other people said, was back in 2023, I was just looking at the blueprint, just trying to figure out kind of what the blueprint is used for and their care coordinators and kind of what like that the basic is. And it is that they are supposed to be coordinating care to get people to the right care at the right time and access in place. There was 180 FTEs, and I calculated that only 9% of Vermonters went through them to get their care coordinated in a timely manner. And so I just wonder if, and maybe those numbers have changed dramatically since I think that was probably from 2021 numbers that I analyzed. But maybe that's changed. But to Allison's point of kind of leveraging our resources to educate people where and when to use the right type of healthcare, because I've also had a lot of people calling me wondering what to do. I have 2 young children. This winter's been awful with illnesses. And they were calling me on a Saturday or a Sunday, and they're like, all I'm getting is answering lines, and my kid has an earache and flu and RSV and the whole everything. And, when I ask them, a lot of them are going through the UVM PCPs, which just makes sense. It's what's available and it's what most people have access to. But for them, those practices not to maybe have a triage line, like a nurse triage. And a lot of times I know as a parent, especially with young kids or even myself, just to talk to someone for 5 minutes. And even if it's a charged 5 minutes, that's a lot cheaper than going to an ER, the UVM ER with an ear infection on a 5-year-old. And so maybe that could be another just way to navigate this. And it goes back to Allison's point of just education. And sometimes it's just having that person like, okay, it's Sunday, there's an earache, do X, Y, Z. I also my kids go to Richmond Pediatrics, which Paul Parker is always on call. I don't think the man ever sleeps. He's a wonderful human being. But that type of service, I think, could go very, very far with just helping people be at peace. And especially, we are a rural state. People don't always have a neighbor to go knock on the door and ask for something, or maybe they feel a little isolated. So a triage line of some sort, maybe an UVM or other, and not just to call it UVM. Maybe there's a lot of practices, but I know that could really help because I found myself as a triage person, and I am not a doctor, so I do not want to give medical advice. But people just think I'm in healthcare, so I could give them advice. Another thought I had, or a quick story, was around efficiency. And just, again, it's like the right care in the right location. And it's like outside of surgery, outside of anything. I just think sometimes certain level hospitals and maybe their practices and efficiency are just best place within certain realms, and it'll make sense. I called Women's Health back in December, just, they cover everything at UVM, just to make a normal appointment. And this was in December, 3 weeks before the start of 2025. And I was told I couldn't get scheduled for a normal outpatient, just appointment to talk to someone. And I said, no, I don't need like surgery or anything. I just need to talk to someone. I just need to schedule an appointment. And they said our provider schedules are not ready yet. They won't be ready for 2 more weeks. And I said, so how are you scheduling people in 2025? And they said, we're not until our provider schedules are published in 2 weeks. So a week before the year starts. So I laughed, honestly, and I said, you're joking, right? I can't schedule an appointment for 2 weeks and your whole calendar is empty. And the woman didn't, she was just doing what she was told. And that was that. And so I just have to think how many hundreds, thousands of women, and if more departments are ran like that with such inefficiency, what a backlog and to scheduling right there. And so that inefficiency in itself, that's creating a wait time. And I just don't think that that's appropriate or effective. And so these types of things in themselves, I support hospitals, I support independence. I don't think it really matters. I just think these types of little access things, that if they were just run a little bit better and a little bit more efficient and just push through, and I don't know the answer, like everyone else is saying, I don't know how to do that. I do that at the surgery center, and I bark up some trees and we get things rolling. But I don't know. I just think those 3 things, just getting the right education, as Allison was saying, so people know what to do when things aren't going great, instead of ending up in the ED. Maybe we're working with some triage lines to get some resources and just have someone answer that phone. And then the last one is just scheduling. That's a real burden, and especially being told that their whole schedule shut down for an entire year, 2 weeks out.
Thank you, Elizabeth. I see Jeff McKee next. Oh, sorry, I skipped. I'm looking at Kathy. I almost skipped over you. You're next.
That's okay. I'll try to be pretty brief here. I know everybody's got I've been on this group for a while, and I want to give other voices an opportunity. And actually, I want to thank the folks that have been speaking to the clinical pieces, because you've all shared actually boots on the ground experience that I think highlights what I see as the global problem right now in healthcare, and that includes in Vermont, and that is our clinical and operational inefficiencies. And so every story that you said about a triage line, about lab tests, all those things are very true. And I think combine and add up to the problem that we have now. I noticed, I want to speak on a higher level for just a moment. And by that, I mean, I belong to different conversations around healthcare nationally and et cetera. And we are not alone. Vermont is by far alone in this battle. There are some success stories nationwide, but Vermont is not alone any more than any other state is. And so have we looked, I would just ask the board, and this is sort of rhetorical, I don't really want to get into the weeds with a true answer, but I wonder, do we know of a place of excellence? Do we know of a community? Do we know of a healthcare system of excellence? Are there lessons to be learned from other places that actually, in spite of the environment nationally, are actually doing okay? I saw in one of the reports that was sent out talking about RVUs, that we need a report on RVUs. I have come to not like an RVU system at all, and I would point to Kaiser in California, that they do quite well financially and clinically. And how do they do that without having an RVU system? What's the downside of an RVU system? The downside of an RVU system is burnout, and lots of procedures and tests and things like that. So have we looked to that? Is there an opportunity to learn from a system like Kaiser, which probably covers more lives than the whole state of Vermont has? So I think we can get some information from other folks. I think Vermont is ripe for making a huge step. We're small enough that we could work as one system. I know there's probably regulatory stuff that I'm not aware of, but that's what I think it's going to need to get out of this cycle that we've been seeing kind of spiral for a long time now. I think we all have to work together as one system. Lab tests were mentioned. I'm just going to highlight that very, very briefly, because sometimes I think that those of you who don't work actually in the patient-facing world don't understand how messed up healthcare is unless you've actually, like Walter, who's had to go through the healthcare system. It is so poorly regulated and poorly administered. And you talked about, not getting into the clinical appropriateness of care. I don't mean to be a Debbie Downer here, but if the folks in Vermont who want to improve healthcare do not get into the clinical care that is given, we'll never get there, because the clinical care that is given is inefficient, as you just heard people eloquently say. There's lots of inappropriate care. There's lots of reactive test ordering, which we all know happens. And thank you to the woman whose name I forget, was Allison, who talked about what it's like to be on the front line in the ED. If we don't get around that, if we don't put structures in place to prevent unnecessary care from happening, we'll never fix this. We won't. Cholesterol profiles, I don't reveal your personal health information, but I'm just going to ask this group, how many of you have an annual cholesterol profile that your primary care doctor orders? Probably many of you, or your spouse does, or partner does, or whatever. Very few of you need it. You only need it if you're actively being treated for something and something has changed. When you have a cholesterol profile, it ties up the system. It takes 4 or 5 slots in the lab. Imagine how many thousands of Vermonters a day have a cholesterol profile that they don't need. It goes on your doctor's desk. Your doctor has to make a decision what to do with it. And either the doctor has to contact you or the staff has to contact you. That's just one tiny thing that happens repeatedly throughout the country and throughout Vermont. And I'm not saying the solution is through cholesterol profiles, but my point I'm trying to make is that there is unbelievable waste in the system. I don't think that unless you're providing that waste or personally experience that waste or trying to navigate through that waste, I just don't think it's comprehensible the current state of affairs is right now. And lastly, at some point, I don't want to take any more time here, but I'd like to better understand how UVM could make a profit. When I read that, I was shocked that a tertiary care medical center could actually make a profit. And I know that there is some regulatory angst over that, and I understand that, but at some point, I'd love to hear more about that. And did we learn anything from that in a positive way? Thank you.
Thanks, Kathy.
I have a question. I can address that, I think, at a high level, and then I have a question too for the group. It sort of transitions to another topic. So I'll throw it out there and we can get to it. On the profit, and just the word profit will be, people will tell you it's not the right word because they're nonprofit, so there is no profit. But yes, UVM made a positive margin last year.
Right.
I forget the exact number. It might have been, I think fiscal year 24 might have been 2.7%. I forget the millions of dollars that was. But yes, they did have a positive margin and a positive total margin. The fiscal year actuals are up. If you want to see those numbers, they were at the last board meeting on last Wednesday with every hospital's financials. And then I agree with we do get into the clinical operations when we look at, how your provider productivity, the quality, we get data on utilization of the ED, but how do we, I don't think we are as granular as you're suggesting we should be, which is, are you ordering unnecessary tests? And how would we go about doing that as a regulator? And we have our guidance out right now. And if there's things that we should be thinking about in that process to get at that question, I think we'd definitely be open-minded to it. But how would we do it? How would we go about that?
Well, first of all, you need data. You need to know what we're doing currently. So if someone, what are primary care doctors doing for annual screening? I'm just keying off what I said about cholesterol. But more importantly than that, if someone comes in, ask the clinicians, ask Allison, if a 5-year-old comes in with a cold, what happens? If someone comes in with a headache in the emergency room for 3 weeks, what happens to them? So I don't know where the baseline is, Owen, and that I think is what I see is sometimes missing. I think we haven't really, and I say we, the collective we in Vermont, that's what I mean. I don't mean anyone particularly in this room. But I've not seen that kind of effort. And I came from a system that's bigger than the whole state of Vermont. And so there are hospital systems that are much larger in patient volume and residents and members than the state of Vermont is. So how do they do it? They do it. How does Kaiser, a huge organization, what is their structure like? How did they do it? How did they get their doctors to order the right tests? What's their feedback system? What kind of data do they have? I'm sure they all work on the same system. That's one simple thing. We don't have that in Vermont. So that may be a longer term pace than the urgent need we have right now of what, oh my gosh, those numbers look terrible that you showed in the beginning. So
Yeah.
I think infrastructure, looking at our current state and then putting infrastructure in place so that we can find the variation as it occurs is the way to go. I just don't think we'll get there without that piece.
So trends in certain types of services being provided. So for example, are we seeing, what's our baseline? Are we seeing a spike in some particular service line or some particular test, that kind of thing?
Sure, that's a good place to start, but you can do that. You can do this in parallel. So you can do what you just described. You can pick a few things that you want to look at. One topic I worked on once was blood transfusion. What do blood transfusion look like across the different hospitals? And that's pretty easy to track. And not that we're going to target blood transfusions, but at least it gets the teams in the mindset and puts a structure together where you're actually looking at how is care being given? What are we doing?
Just to piggyback a little bit on that, this is Kate Merchant. Hospitals do have metrics like that, and we have utilization review committees where, if we're seeing increases in specific testing or increased length of stay, just a couple of examples, those should be filtering through utilization review committees with the intention of improving quality and care, essentially. So a lot of that type of data, at least for hospital systems, is already out there. It's things that we report to CMS.
Right. So exactly. So there are places, but is it the same, Kate, from one hospital to another? Is there a way that someone can get, a report across all the hospitals or all the facilities to see, as you said, Owen, you're looking for an opportunity, right? Why is it this way in hospital A and that way in hospital B? I don't know how much that happens, but that's really the driver of the high cost. It's the inefficient care, whether it's how soon you get an appointment or how long you wait in the ED or what labs are ordered because you're afraid you're going to get sued or the patient's going to get mad at you. It's all of those things. And if we don't as a state look at that, we're not going to succeed.
Thanks, Kathy.
Thank you.
And now I will turn it over to Jeff McKee. Again, if you could just tell folks where you're from, Jeff, that'd be great. Where you're working.
Yep, Jeff McKee from the Community Health Centers here in Burlington, serving FQHC, serving Chittenden and Southern Grand Isle counties. So I thought I knew what I wanted to say, and then the conversation went on, and now I'm thinking about other things. But the original thought I had when I raised my hand was that we're talking so much about moving some of the services to more efficient and less costly venues, and I'm all for that. I think the other side of that is that only works to reduce the costs if the higher cost service stops doing what they're doing, or proportionately, commensurately, kind of reduces their capacity as well. So we're just not adding capacity. We have to actually move the service from one place to another. And so that works against the margins that the hospitals are, declining margins that the hospitals have too, right? So there needs to be some thoughtfulness around obviously around the cost structure of the hospitals, and getting kind of a planful agreement to reduce services in some area. So we're not just adding things, we're moving it to the lower cost. I think one of the things that we can, we haven't really talked about, and it doesn't get talked about enough in my opinion, is that, hospitals and all service providers drive their own volume, right? If you open up a particular service line, a hospital will fill that service line to the best of their ability. The only thing worse than an overused service is an underused service from a business standpoint. And so that does drive our utilization patterns. And so coming back maybe to the point that Owen raised around some of the things that we can do, I think we need to look at, for communities of the various sizes we have in each of our hospital service areas, what are the, how much of various kinds of service do we need, right? How much, how many providers, how many different types of surgery should we expect to have, and how should we build for that? Not build necessarily on demand that is driven by people interested in providing that service. And I think we need some benchmarks around what the kind of need is within a range from other places that have similar demographics or adjusted for demographics. But simply looking at what is current demand patterns, I think that doesn't get us there. I think you need an external benchmark to judge that against. Thanks.
Thank you, Jeff. Michelle Wade. Hi, Michelle.
Hi, Susan. For the record, I'm Michelle Wade. I'm currently the president of the Vermont Nurse Practitioners Association. I'm also a nurse practitioner hospitalist at Gifford and Randolph. And many of the things that I had originally on my list, people have talked about. So in the interest of time, I'll simply either say yes or no, and my rationale. But patient education really is part of the problem here. And Allison alluded to that. And I think Liz alluded to that. And I think Kathy alluded to that. And I work in a situation where the patient comes in and demands an exam. They demand a test. They demand a lab. Despite the amount of education that I can give to them, because we do live in a litigious world, unfortunately, sometimes it's easier for me to succumb and just order that test than it is for me to spend hours documenting my rationale as to why I didn't do it, as well as spending time to make it a positive patient outcome. Because heaven forbid, if a not positive patient outcome trickles back to my facility management, then they want to know what I didn't do for that patient, because we're in a customer service world too. So I really feel a patient education blitz, not by each individual facility, but coming from a more global level about healthcare is in crisis in the state. It's in crisis in the state because of the need to pay attention and use good basic medical care. It doesn't mean you need an MRI every time you have an ouchie. It doesn't mean that you need 6 tubes of blood drawn for a lab test. Granted, that's not how we're going to say it to the public. We need to fashion it appropriately, but patient education is a problem. We need to get it out there because we're competing with pharma. We're competing with all these people on TV that say this drug is best, this test is what you need. I lecture all over the country, and I lecture about polypharmacy. And when I lecture about polypharmacy, I talk about the trickle down effect. You get put on this medication, which causes this side effect, which puts you on this medication, which causes this side effect, which caused you to fall in the middle of the night and fracture your hip, and now you're bedbound. This is a same thing in the healthcare in the world today. And I think that we as Vermont can lead the nation with this. We can be leaders and say, this is how we fixed it. My colleagues in Texas and Arkansas have been in the same spot, and they have done big PR campaigns, and it has helped them. So these are some things that I think are an area we could look at. Another thing that was already talked about was the whole RVU versus patients per hour. The only thing I will say about that is tying a provider's income to either patients per hour or RVUs in most cases makes your provider not give the best care that they could give. And I am a proponent of salaried providers versus RVU-based providers and holding the providers accountable for their lack of care if that's the problem. The other thing, when you come back to the granular a little bit about the test, unnecessary test ordering, that again comes back to patient education and the quality management within each organization. Every org looks at this. We look at, in my organization, the high cost tests and go over who's ordering them and why, and do they have a supporting diagnosis. So again, that we need to hold each other accountable on that. My biggest thing that I want to talk about, though, is access to records. I work at a small hospital in the middle of nowhere. My patients get primarily seen for tertiary care at Dartmouth and UVM. I'm lucky enough that I have remote access to both of those organizations because my organization has an IT agreement with them. So I can look and see. And I actually caught a patient shopping just this past week who had gotten an MRI and a CT at the ED at CVMC and didn't like the outcome. So they drove 20 miles down the road to Gifford and tried to get the same thing all over again. But if I didn't have access to those records, I wouldn't have been able to stop that. I was able to stop those high volume, high cost tests because I had that record. Allison is at a disadvantage. She can't do that. I also run into the same thing. They get their A1C somewhere else. They're in the hospital with new AFib RVR, or they get their TSH somewhere else. They're in the hospital with new AFib RVR. If I can see a TSH that's 2 weeks old, I'm not going to repeat it. But if I can't see it, I'm obligated to repeat it. So if we can't get everybody sharing records, and Vital's not the right answer, I'm sorry to say, if we can't get everybody sharing records, we're losing a lot of money in repeat testing right there because we're not sharing the same records. And I think the last thing I would want to speak to is that when I was a primary care provider and not a hospitalist, I would send my patients off for specialty care when it got outside my comfort zone for scope of practice. Most of the time, I never got those patients back. And that was wrong. If I send you to get specialty care for, let's just say I need neurosurge specialty care, the patient can come back to me for management on a chronic basis. Same thing with dermatology. I send them out because they've got extensive derm stuff that's outside of the scope for me to punch biopsy or take care of in the office. They can come back to me for regular maintenance, and then someone who needs to get into a higher level of skill can get in and not be on a 2-year wait list. I can do that surveillance and send them back if needed. We're not utilizing primary care providers to their fullest scope of practice, and that's hurting our specialists. I could go on and on, but I think that's a good place for me to stop.
I had a question on one of those, if you don't mind me interrupting,
Yeah.
Susan.
Yeah,
So
go for it.
when I was at the U.S. Attorney's Office, I did a bunch of cases involving clinical decision support alerts being used in nefarious ways. Are there any technologies, AI technologies or CDS technologies the state could use to flag, hey, this test was done 2 weeks ago. Doc, are you sure you want to reorder it? Why isn't there technology that flags that?
I don't have the right answer to that. There probably could or should be, but it would be required that everything was loaded into a database that AI could read.
You also would need to all the individual EHRs. A lot of us are ordering them within our own EHR. So the problem is that like the system doesn't know that I'm seeing Joe whatever and ordering, because by the time the test works its way through, it's already ordered, drawn, and on its way.
No, but I mean, at
There is
least, at least
technology,
for,
Owen.
I'm sorry?
There does exist such technology, but that was sort of what I was getting at earlier. But I applaud what Michelle said. She spoke very eloquently. But that's the structure that has to be put in place for us to figure this stuff out. Is if everybody has a different EMR and they don't talk to each other, a provider in hospital A can't figure out what a provider in hospital B did last week or even in the morning. That's a huge problem. So it gets ordered again. It's much easier to get it ordered again than to actually call and have someone look it up in another system and et cetera, et cetera.
And it's not
least,
just the
I mean-
hospitals, it's primary care too, because
Yeah,
they send stuff
exactly.
out to Quest, they send it out to various labs.
That's true.
And I know most of I assume there's a pretty big difference between the EMRs used at the FQHCs. They're mostly on eClinicalWorks. The larger hospitals are mostly on Epic. So I'm thinking like across the hospitals, you'll capture a huge swath of the patients and the orders because most of them are on Epic. But then when you go to the other non-hospital providers, there isn't that connectivity.
Only UVM and CVMC and their network is Epic. Rutland is Cerner. Gifford is Meditech. Bennington is EDH. So it's not, and we just went to Meditech 2 years ago when I was on the committee. Epic wouldn't even talk to us. We're too small. Cerner quote to us was unreachable.
Yeah, Scutney, Dartmouth, they're all on Epic. Scutney, Dartmouth.
Because they're all
I
under
think
the Dartmouth
SVMC.
umbrella.
Right. So you got
I mean,
the
you're-
three UVMs in New York, the three Dartmouths. That's
Right.
I mean, you're not going to get everyone on the same EHR because most practices have chosen an EHR based on their needs, and the needs are very disparate across the state. What you need systems that actually talk to each other so that when someone has a TSH at UVM or Dartmouth or Copley or at Quest, that when I pull up the patient in my system, that lab loads into my system as well so I can see it. And that's what I think they're working on, and some of the other committees I'm on, that's what we're working on. But that's an expensive endeavor because for most practices, building an interface is $10,000 or $15,000, and it's $1,000 a year to maintain it. You're talking about practices with very small margins. They have to know that there's a cost benefit to investing that amount of money. And there isn't from a small independent practice perspective. There is from a system perspective. But the goal is to actually have it so that stuff gets done, in one place and everyone sees it, so that the ER is not reordering the CBC that I literally just ran in my office 10 minutes earlier. But the technology, it's not that the technology doesn't exist, it's that it hasn't been developed to where it needs to be for that to be instantly available to everyone.
I mean, we could look at mirroring it after pharmacy. Okay, when a patient comes in, I can pull an external report that brings in every fill they've had anywhere in the United States, except the VA.
That's because they all use the same. Is it SureScripts they all use?
They all
But
have the same
SureScripts is just a hub.
clearinghouse.
I mean, that's like the
think
VHI. SureScripts is just a hub where everything feeds
Yeah,
into.
I know, but they all. Right, but I think that's where they get it from, is because it's all feeding into SureScripts, I think.
Right. So for us, it would be everything feeding into the VHI and then everyone being able to pull out of that and it being done in a cost-effective and timely manner. Which would cost money that we don't have.
Right.
But if we save the money from repeating all of those exams and all of those tests, we might have it.
I'm just looking at the time. Tom Walsh, did you have something to say? I thought I saw you come off mute, and then I'll go to Andrew.
Well, I did, but
That's all right.
I think
We have-
Andrew and Sharon should.
Okay,
should.
okay, and then we could come back. Andrew, please.
Yeah, good afternoon. I'll be quick. There have been so many ideas that have been shared already that are consistent with what I've run into. These may not be terribly different, but I'm recalling Alex talking earlier about, the reimbursement they had with Blue Cross versus the hospital. And I know the Care Board asked recently asked for rates, what we were getting reimbursed. And what I wanted to share on that is they don't cover our costs, what we're getting paid from Blue Cross. So there's that, and that's about 30% of our patients and visits. We have a little over 7,000 patients and about 43,000 visits a year. A lot of behavioral health on us, where the reimbursement is well below our costs. I also, last year was the first year we were in an ACO at Little Rivers. We're a federally qualified health center, and we were in a Medicare only ACO and the REACH program. But it gave us some neat insights. There were issues too, but one neat thing we got was insights on the costs for by patient on traditional Medicare beneficiaries. And I just saw a huge difference for the same procedures from Dartmouth. We're near the New Hampshire border. We're serving a lot of Vermonters, but they're getting care in some New Hampshire facilities. So Dartmouth and Cottage Hospital in Woodsville. And the costs for the same procedures at Cottage Hospital were far below those at Dartmouth. So it's the first time we really saw that in a very informed way. I also, I don't know how big this is across the state, but now an adult and in unmedicated remission, but my daughter's been chronically ill, about 16 years on Remicade. And we would go to Massachusetts Eye Research and Surgery Institute, now in Waltham, used to be in Cambridge, Mass, and get Remicade for the $650 visit plus the cost of the drug. So, you know, going back many years, that would have been, say, $3,000 the whole bill. We'd go get it at UVM, Dartmouth, or NPRH, and it would be almost $8,000. And I used to view it at that time sort of like a real estate fee. But I wonder if that kind of service is an area where we could safely save some money and improve access. If you've got to drive to Massachusetts, or even I live in St. Johnsbury, go to Burlington or Hanover for the day, you're not going to do much else that day. You're going to miss school and work and so forth. So there's a lot of economics in that on a personal level and on the healthcare system expense side. We also have a growing number of physicians and some certifications with nurses and lifestyle medicine here. And we firmly believe that a lot of the needs that we treat people for every day could either be of a lower acuity or maybe not exist with a change in lifestyle. And I don't know exactly how we're going to have forward motion on that, but we're excited for the possibilities of improving our population's health through lifestyle medicine practices when we know how to do that in terms of getting paid for it. That's it. Just add to the conversation. Thank you.
Thank you, Andrew. And Andrew's the CEO of Little Rivers Healthcare for new folks. Thanks, Andrew. And Sharon Betlin.
Yeah, I just wanted to follow up. I mean, I understand how shifting care out of the hospital means that they have less. But the truth is that the hospital will never be able to compete with the accessibility and affordability of community-based care. So again, we need to basically start with affordability. We got to bring the prices down, and that is a way to do it. Now, if it costs more in the hospitals, then we need to pay more, and we could have more if we save. Same with the informational hub. I agree that there's money to be saved if we could have interconnectivity so that all the information of patients comes available to every provider that needs to see that information and have it be instant. I thought that Vital would do that. It's disappointing to hear little faith in it, but to get there. So technology is going to save us money, along with identifying the best places of care. just like we identify a hospital as the best place for care, for critical care, we have got to shift care to system we can afford. That is going to be more complicated than site neutral for sure. It requires more auditing and regulation to make sure that it's followed. But with UVM at 358 now, and actually it's 382% of CMS for physical therapy, understand that outpatient physical therapy is at 113. So it is not like we are going to need much more, not as much as a hospital has money to save if we could get the care out of it. It's not acceptable to have any business basically use people and use services to make money for something else. We need to find out what it is that they need money for and have it be legitimate and pay for that. But we aren't going to get there to be sustaining our hospitals on this route, because we've been on it and it's getting worse. So to continue to think that, oh, we just need to pay more for the hospital to keep having expensive services makes no sense. We've tried that. And the longer that we continue on that path, the less we're going to have the ability to have the affordable system if our independents go out of business. I mean, right now we need more providers. So we need to basically keep them, which are in roles of delivering affordable, accessible care. We don't want to lose that. I used the analogy of a centipede has a lot of legs. Now it's the community-based providers that are really the best at providing that direct care, establishing relationships with their patients over a lifetime versus go to the hospital and see something new maybe every time you go. Those centipede legs, if you knock them out, you're going to have a centipede on the ground and it's not going to survive. So in other words, it is not the hospitals that should be the leaders of healthcare, but all the many providers out in the community getting the population healthy and keeping them healthy and in the most affordable, accessible way. So whatever you want to do that, it has to be done very quickly. Like this year, there has to be a change. And you mentioned that, again, I do want you to know that no matter what a payer might say about them basically beefing up the payments to primary care providers that are independent, it's not happening. Now, I don't know how. I know you can't audit that. And I think that it's just important, just as you are listening to them say so, you got to listen to other people say, but we're not appreciating that yet. There's a disconnect enough for you to have a curiosity as to why is there a disconnect? Why are Blue Cross and Blue Shield saying that they've increased, whatever percent more, but we're hearing in the community that is not happening? Where's the disconnect? I don't know. So I think, again, unfortunately, in too many meetings, there is an executive session and anything can be said there that is not challenged. And now that we have price transparency, I don't see the point of having there be executive sessions, because we all know. And that is, like, I can show you from their own websites how radically different they pay for services. It's astronomical. So I just want to emphasize that, because we're running kind of out of time to even say it.
Thanks, Sharon. Thank you. John Macy. Hi.
Hi, I've been sitting quiet. John Macy at Copley Hospital, orthopedic surgeon. So I have two quick questions. One goes back almost to your first slide, and we've been talking about no surplus in the system whatsoever, but yet you showed this slide of Blue Cross Blue Shield having a surplus going downwards, but I believe the number was like $80,000 surplus. So where does that money go? What is that all about? If you could explain that slide. And then the other question is one, I'm wondering, where are we at in the discussions that are going on at the legislator level about the Oliver Wyman report and the recommendations and this sort of consolidation and redistribution of healthcare services that was, really looked at in detail?
I can start with your second question first, and then we can see if we can get you more clarity on I think you're talking about the RBC slide that I showed on Blue Cross. So right now, our colleagues at the Agency of Human Services are working on the transformation part of this work. They are taking the recommendations from the Oliver Wyman report, working with hospitals and other community providers on next steps and assessing feasibility, et cetera, on those recommendations. So they have a contractor. We are part of those conversations. We have a staff member who attends the meetings with AHS. And so that's what I know in terms of the next steps on the Oliver Wyman report. I'll also say, getting back to the legislature, many of the recommendations that the Oliver Wyman report put forward I can speak for the Green Mountain Care Board, for example, they recommended that we look at our CON statute and perhaps change some of the thresholds, which is something that we worked with the legislature on this session, and that bill just passed out of the House, and now it'll be going over to the Senate to change the thresholds. One of the other recommendations that came up today was around the communications around the EMRs, and I know Senator Lyons has a bill with a data section in it that I think is trying to address that. So, those recommendations are being pulled through, both at the work that AHS is doing on transformation as well as at the legislature. Does that answer your question, John?
Yeah, thank you.
Okay, and we can connect you with Brendan Krause too, who I think can give you more about the transformation work over at AHS. And I'm not clear, your other question about I can pull up the slide,
You had a slide that showed a surplus, and everything that we've talked about is negative numbers, maybe a 1% margin, but yet you showed this slide with a surplus, decreasing surplus, but still a surplus of 80,000 something. I couldn't see it so small on my phone.
Yeah. You didn't mean, let me pull up the slide. I can look at that. I think the point of, and I'll just say this, and I can follow up with you too. I know we're running over. The point of that slide is there is that range for the risk-based capital, and that, the assets to the, what the insurers are paying out versus what they're essentially bringing in. And there is a range that it's regulated by the Department of Regulation, and it's a recommendation for insurance to stay within that range. And I will look at the slide that you're bringing up, but they are going down significantly. And I know I don't have the number. I saw Sarah teach out here earlier.
Sorry, Susan, I think I can.
Yeah, go for it.
John, are you talking about the insurer surplus slide?
Yes.
Oh,
I believe it was
so
Blue
yeah,
Cross Blue Shield.
Let me see.
I don't know that I'd call it surplus. That sort of sounds like they have additional money. The fact is they have nowhere near enough surplus. It's reserves to pay claims. I think there's testimony on Friday that they have, absent a $30 million loan, they have $28 million in the bank. And to give you a sense of scope, they lost $10 million a month in the fall of last year. So I think surplus sounds like extra money. It is not that. They're at a company action level event where the state needs to step in and take action. It's surplus, I don't think is the right way to think
Yeah.
about it. It's they kind of have the
That was
opposite
my
of a surplus.
understanding.
Yeah.
Okay.
That's my understanding, Owen. I'm just wondering if you're presenting these slides in public, that those are the right terms to use. Thank you.
It's reserves is the right word, and the reserves are drastically too low.
Thank you, John, and thank you, Owen, for explaining that. And to, again, a somber
When-
place to end, but yeah, we'll send out that recording from the finance committee. I'm eager to look at that too, to get the latest update. John, did you have something else?
And the only other thing I was going to say is, Robin, it's been a pleasure serving on this board with you, and I'm going to miss my Dartmouth colleagues. But will there be a replacement for Robin? Is that in the works as well? Is there a succession plan? I am not looking for more work.
There will never be a replacement for Robin Lunge.
No.
But yes, this has been under recruitment. We do not do the recruitment. The Green Mountain Care Board does not, as part of the statute. It's a committee, a 9-member committee that has the interviews. They posted the position back at the end of last year. They interview and they send all qualified candidates to the governor, and the governor then appoints the position, the board member, and then that is then approved by the Senate.
Thank you.
So
Nothing
we should
further.
know soon. And last year there was legislation that passed that streamlined the dates and the process so it wouldn't linger on. So this will happen, I assume, fairly quickly. It should, because of the new statute. But no replacement for Robin Lunge.
Thank you for your kind words, everyone.
Thank you, Robin.
And I'm sure I'll see you around, John.
Yes, you will. Maybe a reunion next
Good
week.
luck,
whenever
Robin.
that is.
Thanks all.
Okay, with that, I should probably open it to public comment. We had some folks comment, but let me just put that out there in case there's anyone who wants to provide a public comment. Thank you all for such a robust conversation. I took copious notes. So thank you. And we'll be out with our next meetings. They haven't been scheduled for next year, so we'll be out very shortly with those for your calendars. Thanks, everyone.
Thank you. Bye-bye.
Bye.
Danny is still in the meeting.